I think we have most people who have actually joined in. We really appreciate seeing everybody today. For this CML Highlights of EHA, we're pleased to welcome Professor Wolf from Austria and Professor Tim Hughes, who will be giving both the clinical and biological highlights from the recent EHA hybrid meeting. So at the beginning, I would like to introduce Professor Dominik Wolf from Austria. Professor Wolf is Director of the Hematology and Oncology Department at the Medical University of Innsbruck in Austria and Speaker of the local Comprehensive Cancer Centre. His research interests include immune regulation in cancer, tumour microenvironment in MPN, stem cell transplantation and autoimmunity. So Professor Wolf will share with us the biological highlights for CML from the recent EHA meeting. Professor Wolf.
So thank you very much for your kind introduction, and hello to everybody out there and around the globe, including also Tim in the Australian outback. It's great to have you here because obviously your connection is not perhaps perfectly working, but actually we are very happy to see you. I hope I get started. I will share my screen, and it's a great honor to present some of the scientific highlights in CML from the last EHA. You may have joined in the beautiful city of Vienna here in Austria. I've selected 3 abstracts, which I think could be interesting also not only from the biological understanding, but also for future translational approaches to improve therapy. You know that CML is one of the classical myeloproliferative neoplasia arising from a common stem cell. Most of the patients have Philadelphia chromosome and BCR-ABL positivity. And the disease is, the hallmark of the disease is increased white blood cells and left shift of the differential counts. But you also know, or might have heard, that CML is a wonderful model disease to study the interaction between the immune, or let's say the inflammatory microenvironment, and the Philadelphia positive or BCR-ABL positive clonal hematopoietic cells. And I think this is of particular importance because we know nowadays that directly targeting the BCR-ABL molecule or the clonal cells is quite effective, but actually we are not able to delete the Philadelphia positive stem cells because they are less BCR-ABL dependent, less TKI sensitive, and probably more inflammation sensitive. And this interaction between the remaining stem cells and the inflammatory microenvironment, I think, is of utmost importance to also better understand disease persistence, but also to generate novel ideas how we can better use the immune system against the disease. A very important abstract has been presented based on the observation coming from different groups, including ours and also Tim's group from Adelaide, knowing that NK cells are affected in CML by the disease itself. At diagnosis, we have just recently reviewed the different findings. There are several phenotypic and also numerical changes in the NK cell compartment without going into too much details. And then people have also nicely demonstrated how this is changed, how the NK cell compartment is changed during therapy with, for example, Imatinib or second generation TKIs such as Nilotinib and Dasatinib. And also at the NK cells and the phenotype of NK cells and also expression of specific killer inhibitory receptors is associated with the likelihood to develop molecular response, but also then with the likelihood to stay in treatment-free remission. So that is the basis, which is set by previous data. And based on these findings, the group of Satu Mustioki and Petra Nygren have presented an interesting approach where they try to screen for drugs which are able to modulate NK cell activity. And they have done this based on the idea that the NK cells may be directly modulated by selected drugs to improve their efficacy against remaining, for example, remaining BCR-ABL positive cells at the time point of deep molecular response, where we know that, for example, that NK activity is linked to the likelihood to stay in molecular remission. And so there could be the idea, I mean, you may have heard of the study of Andreas Burchard from Marburg that he's using in this particular situation pegylated interferon in a randomized trial. We haven't seen the data so far, but actually also interferon is not only directly targeting the CML positive stem cells, but also able to activate NK cells. So this idea of improving treatment-free remission by modulating NK cells, I think, is appealing. Satu's group has now used a systematic approach where they co-cultured leukemic, BCR-ABL positive leukemic cells, cell lines K562 together with NK cells from healthy donors. I think this is important. And they have exposed these co-cultures, or as control, the cancer cell-only cultures to a drug library. And they have then looked whether they can increase the NK activity against the leukemic cells by exposing those cells to the drugs. And in a second step, they try to understand, I think this is one of the strengths of the lab of Satu and also Kimo Porca, that they really go into mechanistic approaches. They observe things either in clinics or here in cell biological approaches, and then they try to understand by omic methods, for example, here single-cell RNA sequencing, trying to dissect the mechanisms. Why is this specific drug A able to activate NK cells, and to better understand the underlying mechanisms? And using this approach, they have found a number of drugs which are able to activate NK cells, and it's particularly SMAC mimetics. There's two different compounds, one which is obviously not able to be then also tested in early clinical developments, and the second one is birinapant, which they have then also used to validate their findings, because they have shown that in the combination of the drug only with the K562 cells, or the combination with NK cells plus the birinapant SMAC mimetic, that they are able to boost the NK activity against the target cells. And SMAC mimetics are known that they inhibit XEAP, which is a known inhibitor of the caspase-dependent apoptotic pathway. When you inhibit, when you expose the tumor cells to the SMAC mimetics, you can modulate the NK activating behavior. They have validated their findings by single-cell RNA sequencing, and have demonstrated that you have an upregulation on the single-cell level on the NK cell compartment of different immune modulatory receptors, such as CD74, chemokines, but also death receptor pathways, including BRC3 or also TNF SF10, which are involved in the regulation of NK activity. So this could be an explanation why the NK cells are, in the presence of the SMAC mimetic, more effective in terms of killing the leukemic stem cells. So that's still early data, but I like the setup. I think it's important to use drug libraries not only to test sensitivity towards of leukemic cell towards specific drugs. Perhaps some of you have seen a publication where we contributed also patients in cancer discovery recently from Vienna, where we screen in a systematic fashion patient samples from hematological patients to drugs. There are various other nice papers out there, but here this drug screening is more towards the question, how can we modulate modulate the tumor microenvironment or the tumor immune system. Here in this project, in particular, how can we modulate NK cell activity against CML cells? They've shown that SMAC mimetic sensitizes K562 to NK cytotoxicity. This induces specific transcriptional changes without too detailed reports in this paper, but it's, as I said, still quite early work. And I think there will be some more very interesting data coming from this project. And I think this is a very interesting approach, but this has to be validated in preclinical murine models. And also we have to understand better the mechanistic background. And we also have to understand how are the SMAC mimetics modulating NK cell activity against the CML stem cells, for example. The second abstract focuses very much on epigenetic regulation. Now we go from the tumor microenvironment, from the NK cells to the clonal cells, to the leukemic cells, and it deals with ZD2. It's a protein which is involved in histone modification, A3K36 methylation. So it affects different levels of regulation of gene expression by direct transcriptional regulation. It induces a crosstalk of histone modification. It has non-histone targets. It modulates DNA damage repair, and it also is involved in alternative splicing. This is a recent review focusing on ZD2 biology, and it has also been shown that ZD2 deficiency induces DNA replication stress in hematopoietic stem cells, which results in proliferation and cell cycle abnormalities and genomic instability, allowing the accumulation of secondary mutations that synergistically contribute to tumorigenesis, and it's also important for HSC self-renewal. So the question is, how important is ZD2 in CML? And this has been addressed by the lab of Simona Soverini, presented by Petra Mancini at EHA as oral presentation. They first have looked into ZD2 protein expression, healthy donor, chronic phase, mutated chronic phase, accelerated phase, myeloid and lymphatic blast crisis, and you can see that the more aggressive, let's say the more aggressive phenotypes of the disease have a lower ZD2 expression levels, and the specific questions were to assess if CML progenitor cells display ZD2 loss of function. So they isolated CD34 positive cells, and then they targeted ZD2 and asked the question whether this induces genomic instability in CML models. And they asked the question how or what happens if we reinstall ZD2 expression, how does this interfere with the proliferative potential, for example, of CD34 positive cells from primary donors. And when we now look into the CD34 compartment, you can see that this downregulation of ZD2 is primarily seen in patients which in patients in the stem cell, more immature stem cell compartment. This holds true for chronic phase CML patients, but also for accelerated phase CML patients. And they have also shown that the DNA repair genes such as MSH6 or RAD51 is induced in the CD34 positive compartment, and this correlates to the downregulation of ZD2. And if they knock down ZD2 in cell lines, in LAMA84 cell lines, they see that there is an alteration of the DNA damage repair response. They've also shown that ZD2 overexpression limits proliferation. So here you can see that the overexpression downregulates the colony formation and thereby inhibits the proliferative outgrowth if you reinstall ZD2 in CD34 positive cell lines. So ZD2 behaves like a tumor suppressor in CML. Loss of ZD2 is linked to genomic instability. DNA damage repair is affected by ZD2 knockdown, for example, in cell lines. And if you restore ZD2 expression and function, this restores the proliferation controls in cell lines and also in primary CD34 positive CML stem cells. So the question is, are there mutations in SETD2 in the SETD2 genes detectable? Is loss of SETD2 and CD34 positive CML stem cells BCR-ABL dependent? And they have to validate their findings also in preclinical murine model. The third abstract, which I found was pretty interesting, dealt with circular RNAs, which are non-coding RNAs that were first described approximately 4 decades ago in 1987 in Cell. They have been shown to have protein coding potential. That was quite recently been published. And circular RNAs stem from aberrant splicing called back splicing, and they are characterized by a perturbated arrangement of exons. And this is the basic observation from a US-American group, which they took to transfer this to a CML model. They also said that circular RNAs have functional significance. They can act as microRNA sponges, so they can bind microRNAs, and in AML it has been shown that circular RNAs can stem from recurrent chromosomal translocations. This is also quite recent data, and it's also linked to prognosis in AML. And the group now focused on 4 previously identified prognostic circular RNAs, which you have shown here. The most promising here was circular PCMTD1, as they have shown that this really very profoundly affects the biology of these cells if you target the circular RNA. So they have performed knockdown screening experiments using nucleic acid modified oligonucleotides. They call these GAPMers that target the backsplicing regions of the candidate circular RNA, so they can reduce the expression of the circular RNAs. They accept the circular PCMTD1. They did not see any impact on the biology, but they very much focused on this circular RNA here in CML blast crisis, where they have seen the strongest phenotype, which you can see here in K562 and LAMA84 cells. The targeting of the circular, but not the linear PCMTD1 profoundly affects the proliferative potential. You can see here the knockdown of the circular RNA, but then if you watch here the cells, the proportion of cells in the S phase and the proportion of cells in the G2M phase is dramatically affected by knockdown of circular PCMTD1, and this very much correlates to inhibition also of proliferation. And in blast crisis CML, the PCMTD1 circular RNA co-localizes with polysomes. This is shown here, in particularly in the blast crisis patients. This is a basic observation how they explain the function of these circular PCMTD1 RNAs, which are also co-localizing with a BTR complex. It's a complex which is very close to the sites of DNA replication. You can see if you knock down the circular PCMTD1, the co-localization with the important complex, including, for example, topoisomerase 3A and PCNA, is affected. In vivo validations are ongoing, so they are transplanting currently 2.5 million CML blast crisis cells, where they have, which they transplant into busulfan pre-treated NGS mice, and they then start applying GAPMers to target PCMTD in those patients by intraperitoneal application of either control or the targeting drug, and they monitor those mice for survival and also for outgrowth of CML, but we don't have seen data here. So circular PCMTD1 is a circular RNA with protein coding potential, which is involved in the DNA damage response of leukemic blasts. It interacts with the BTR complex. It facilitates the complex formation, thereby interfering with DNA replication. And in this context, the circular PCMTD1 derived peptide is indispensable for the proliferation. Again, we have not seen whether these the expression of those, because in AML it's shown that it depends, the production or the generation of these complexes, of these circular RNA complexes, depends on BCR on translocations, and it would be nice to see whether it's a BCR-ABL dependent event that they have increased circular PCMTD1, which is a complex word. And we also don't have seen so far the preclinical validation in murine models, which are ongoing. But I think it's an interesting observation, and I like the presentation of this abstract. So with this, I would like to end and hand over to Tim to go to the clinical findings. Thank you very much.
Thank you so much, Professor Wolf. I really appreciate you distilling all that information and giving your biological highlights of EHA. As we mentioned at the beginning, we'd really like to save questions to the end of both presentations. So I will now like to introduce Professor Hughes, who will be giving the clinical highlights of EHA. Just so that you're aware, Professor Hughes is in Innsbruck, Australia today, so we have pre-recorded his presentation, but he is on the webinar, so we'll be able to answer questions after. So I know most people know Professor Hughes, but as a brief introduction, Professor Tim Hughes is the Precision Medicine Theme Leader at SAHMRI, Beat Cancer Professor at the University of Adelaide, and Consultant Hematologist at the Royal Adelaide Hospital here in Australia. He's also Chairman of the International CML Foundation, Inaugural Fellow of the Australian Academy of Health and Medical Sciences, and Fellow of the Australian Academy of Science. He's been a leading investigator for many of the key clinical trials in CML and has published over 350 papers with over 56,000 citations. So, as mentioned, Professor Hughes will share with us the clinical highlights from the recent EHA meeting.
Well, hello, everybody. I was at the EHA meeting in Vienna. First time I've been live to a meeting for a long time, so it was pretty exciting to be there. There's a lot of good clinical and biological data related to CML presented. I thought I would just present snippets from the 4 oral presentations. I think they're all important, and they all have important messages that we should look at. I'm hoping that some of the actual lead authors will be on the line so they can answer some of the tricky questions if they come at the end. But let's have a look at the data, and I apologize that I am not able to present a broader range of the clinical presentations, the posters. There are a lot of excellent posters, but for the sake of time, I'm just going to focus on these 4 talks. So the first one was an update of the ASCEMBL trial, which was presented by Delphine Ray. And we know that this trial has already presented its primary data, but just to remind people that this is focusing on the this new relatively new drug Asciminib, which blocks kinase activity by binding to a distinct moiety, not to the ATP binding domain. So that makes it quite unique amongst the TKIs. It's very potent and very, very selective for BCR-ABL. And it's now been approved by the FDA for patients with resistance or intolerance to at least 2 TKIs or those with a T315I mutation. And the primary data has already been presented, showing that Asciminib was superior to Bosutinib in this setting. And now we're presenting, or Delphine presented the results of a sort of the secondary efficacy and safety outcomes with a follow-up now of 2.3 years. So a reasonable amount of follow-up now for this study. And just to remind you of the structure of the study, patients were eligible if they had failure or intolerance to TKI, and that this was a second or subsequent line of therapy. So they had to have at least received 2 lines of therapy in the past, 2 TKIs in the past. Excluded some mutations because they wouldn't be responsive to Bosutinib. But overall, it was a 2-to-1 randomization. 157 patients received Asciminib, 76 received Bosutinib. We're now looking at a follow-up of over 2 years. So one of the most dramatic findings from the initial study, and it's still the case now, is the finding that patients were able to tolerate Asciminib a lot better than Bosutinib. So if you look at the patients who discontinued, or perhaps look at the patients who had ongoing treatment, you have 53.5% with Asciminib versus just 19.7% with Bosutinib. So a lot better capacity to maintain patients on drug with Asciminib compared to Bosutinib. And if you look at the second red box, look at lack of efficacy, you see that 24% came off their Asciminib because of lack of efficacy at the latest follow-up versus 35% with Bosutinib. So a significantly higher number of patients coming off for lack of efficacy, but even more dramatic, coming off for because of adverse events. Just 7% on Asciminib and 25% on Bosutinib. And in fact, that figure of 7%, that was 5% after 6 months of therapy. So only 2% of the patients in the recent follow-up of about 18 months have actually come off therapy, suggesting that once patients are settled on Asciminib, it's very unusual to have to come off for toxicity, which is an important message. And this is the looking at the achievement of major molecular response, one of the main targets of the study. You can see it's better at every time point with Asciminib compared to Bosutinib, and it remains better even at the longest follow-up. You also see on the right the maintenance of major molecular response. It's high, as we know it usually is in this setting, both for Asciminib and Bosutinib. So having achieved a good response, you can generally maintain that response, and that's the case for either drug. But you achieve it in more cases on Asciminib. And this is the most recent subgroup analysis based on the 96-week data, and you see that no matter how you cut the patients up into different cohorts, in every case, the analysis favors Asciminib in terms of achieving major molecular response by 96 weeks. And I think that from my point of view, the particularly important thing is that it favors Asciminib most strongly in the more challenging situations. So if you look at the patients who have greater than 1% BCR-ABL, there's a clear advantage to Asciminib. And if you look at the number of lines of therapy, the advantage to Asciminib is there with 3, but it's stronger with 4, and even stronger if patients have already received 5 lines of therapy. And the other important finding is that whether or not a patient has a mutation when they come onto the study, the advantage for Asciminib is equally strong. And in fact, the outcome with Asciminib is pretty similar whether patients have a mutation or not when they come onto the study. So that's all, I think, encouraging longer-term analysis. Clearly, with the adverse events, we know the challenges of Bosutinib at this dose. Some would argue this is a higher dose than would be ideal in this setting. And clearly, we see diarrhea, nausea, vomiting in significant numbers, so shown in blue, in dark blue for all grades, and in light blue for grade 3 or more. And then in green, we see the adverse events with Asciminib, and they're actually very low, except for thrombocytopenia, where it may be a little bit higher than Bosutinib, and neutropenia, but there hasn't been much change. Nearly all of these events are in the first year, and much less commonly in the second year. People didn't get these problems in the first year. It was unusual to get these problems in the second year or beyond. One of the things we're watching really closely with the Asciminib data is the vascular events, the arterial occlusive events, because it's a really important question. Does Asciminib have a higher risk of vascular events than, say, compared to Bosutinib? And how does it rate against Ponatinib, which is a really relevant question today? Well, we had this data, and it was difficult to analyze because so many patients came off the Bosutinib, they weren't able to be at risk of one of these events. But if you look at the lowest category, that's exposure-adjusted arterial occlusive events, in the primary analysis, it looked as though there was a higher number in the Asciminib arm, 3.3 versus 2, and that would certainly be similar at the 96-week analysis, and a AOE rate per 100 patient years of 3 compared to 1.4 for Bosutinib. So it looks to me at the moment as though there may be an elevated risk, but of course it's complicated by the fact that, as you'll see on the right, of the 8 patients with arterial occlusive events on Asciminib, 7 had had prior Nilotinib, 6 had had prior Dasatinib, and 3 had had prior Ponatinib. So I think that would suggest that we need a de novo cohort to really sort out this issue about arterial occlusive events, but it's something we need to watch very closely. So the conclusions from the study were, as you'd expect, that there were higher rates of major molecular response with Asciminib compared to Bosutinib across all of the demographic and prognostic subgroups, including patients with or without baseline mutations. And if you looked at the criteria of being less than 1% at week 96, which some would regard as a more sort of perhaps realistic target of therapy in this sort of very challenging setting, it's also very much in the favor of Asciminib, 45% versus 19%. Clearly, we're watching closely the toxicity issues, and there's no sort of new safety concerns that we've seen in this most recent follow-up. And the major reason that we're seeing this major advantage with Asciminib is because we're able to keep patients on drug and get the benefit of the drug over the longer term. So I think that's encouraging longer term analysis of the ASCEMBL data. The next study that was presented as an oral presentation by Fabrizio Pane from the Italian group was this really important study, a comparison frontline Nilotinib compared to Imatinib used in a very proactive form where Nilotinib is used as soon as patients are shown not to be achieving an optimal molecular response as determined by ELN. So this is the design of the study. Patients over the age of 18 with a typical transcript, and 450 patients were enrolled. Randomization 1-to-1. So half of them received the standard dose of Nilotinib, 600 milligrams. Half of them received Imatinib, but if they were greater than 10% at 3 months, greater than 1% at 6 months, greater than 0.1% at 12 months, they switched across to Nilotinib so that we're able to see whether Nilotinib upfront approach was better or similar to an approach where Nilotinib was reserved for the patients who weren't tracking on an optimal course. What I really like about this study is not just that it's a large randomized study to answer this question, but it's built in a treatment-free remission phase, which I think is going to be really important, because that's really one of our major questions today, is whether more aggressive approaches using more potent drugs actually leads to more patients achieving treatment-free remission. So we don't have that answer yet with this study. We do have the primary endpoint though. And that's shown here, the first primary endpoint, which is MR 4.5, so a deep response at 24 months, which would be where you want patients to be so that they can then maintain that for a couple of years and be eligible for treatment-free remission. And you can see that in the Imatinib arm, it's achieved an 18%, with the Nilotinib arm, 29%. So this is the first evidence we have that it is probably superior, a superior strategy at least, if you're really focused on achieving a deep response by 2 years, to go straight in with Nilotinib rather than Imatinib with proactive escalation where needed. That's very important, but it's really interesting when you look at the data according to the risk score. And I'd ask you not to focus on SOCO. It's a little confusing. I think ELTS is now what we'd all consider is the best way to determine risk in CML until we have more sophisticated strategies. And this is really interesting. If you have low risk ELTS and you have Imatinib with this proactive approach, then 23% will achieve MR 4.5 by 24 months. But if you use Nilotinib, it's almost double, 43%. So clear advantage in terms of achieving a deep response for the patients with a low risk score. Whereas if you have an intermediate or high risk score, really hard to see any advantage in terms of achieving a deep response perhaps an advantage in terms of reducing the risk of transformation. You'd need larger numbers to determine that, but really no advantage in terms of achieving a deep response. So that's, I think, a really interesting finding that needs further investigation. So the conclusions from this presentation was that nilotinib appears to be more effective than imatinib to reach a deep molecular response at 24 months, even with systematic early switching. And the efficacy of nilotinib is prominent, particularly in the low ELTS risk group, which is kind of unexpected, but an important message for us. Okay, the third presentation that was presented at EHA came from Camille Coquerolles and her colleagues, which was a study looking at the value of digital PCR as a way of determining who should and who shouldn't stop therapy in the treatment-free remission setting. So we know that the major indication of the likelihood of success that we have today is the duration of TKI therapy and the duration of a deep molecular response. And that came from very nice data from the Euroski study that Susan Ceceli presented some years ago. Even so, the advantage of waiting an extra year was not huge in terms of improved chances of success. So that was a bit frustrating. We now have some pretty useful biomarkers or clinical features that can help us predict who can stop and who shouldn't stop. We know treatment duration and DMR duration, but also the work of Narani Shanmuganathan and Sue Branford showing that the early kinetics is really important at predicting subsequent success at treatment-free remission, and also the Hammersmith groups and originally showing that transcript type was very important. Having the longer transcript was better in terms of achieving treatment-free remission, B3A2 versus B2A2. And now we also have data about some of the immune cells, as shown there on the right in the right box, and more studies are needed there to really refine what is important. But of course, big question is how important is depth of molecular response? We don't have a lot of solid data to know that. And in this study, they're focusing on studies that have used digital PCR, which is clearly has great precision and arguably better sensitivity. And what they did here was put together the data from the 5 studies that are published, and they're now putting in that data from our study as well, where different groups have looked at this question as to whether having measurable residual disease by digital PCR above a certain threshold, and each of these studies determined a different threshold, gave you a greater risk of relapse. And every study did suggest that the risk of relapse was higher if your digital PCR measurement was high, above a certain threshold. But the differences weren't dramatic. You're going from overall 61% chance of success versus 35%, which is useful, but not as strong as we would like, perhaps. So the question that this group asks is, can we use digital PCR to identify CML patients who may successfully attempt an early treatment discontinuation? And to do this, they pulled all of the data from these studies. So this was basically a meta-analysis based on all of the individual data. And they fed in all of the things that we might think might predict, SOCAL score, gender, age, all of these factors that have been suggested at various times might be important. And in their univariate analysis, the 2 things that came out as strongly predictive were the actual digital PCR value, with quite a strong p-value, less than 0.001, but also the treatment duration. Interestingly, not the duration of deep molecular response, which is kind of surprising, but that's the finding from this study, this meta-analysis. So then they went on to do a multivariate analysis. And once again, it was these 2 variables that stood out, but they were independent of each other. You might have predicted that digital PCR might have gone away if you factored in the treatment duration, but no, it's still predictive. So you need to consider both of those variables to get the best predictive value. And this is an illustration of how this can be used. So if you look, this is the rate of relapse. You see the highest risk is in the patients shown in red, 72% risk of relapse. If their treatment duration is less than 6 years and their digital PCR is above the cutoff, and that falls to 48% shown in green the patients who have duration less than 6 years, where the digital PCR is below the cutoff. So you can see that if you have a patient who's at 5 years of therapy and is keen to stop, it's quite helpful to know their digital PCR value, because above or below the threshold determines whether it's a 50% chance of success versus a 30% chance of success. So I think that's quite valuable. And there's a similar difference in the patients who are greater than 6 years, perhaps not quite as strong. So the conclusions from this study were that the depth of molecular response measured by digital PCR has a predictive value independent from the treatment and DMR duration. That's an important new message. And particularly, you can use digital PCR to identify those patients who are suitable for an early discontinuation, so before 6 years. Obviously, there's more work needs to be done, bigger numbers to really hone down exactly what the predictive value is. Now, Dennis Kim presented important data from his TRAD study from the Canadian group, looking at the possibility for patients who have had one attempt at treatment-free remission and have been unsuccessful on imatinib, whether switching to dasatinib can give them a better chance of success at a second attempt at treatment-free remission. We know that studies from the French group suggest that second attempts at treatment-free remission, where patients have had imatinib the first time and remained on imatinib, the chances are quite low, 12.5% if we just consider loss of a complete molecular response, and about 30% or similar if you consider loss of major molecular response. So the Canadian group wanted to see whether switching to a more potent drug like dasatinib could give you a better rate of success at your second attempt. So this was the structure of the study. Imatinib discontinuation for patients who are unsuccessful, re-challenge with this time with dasatinib, and then dasatinib discontinuation. And the primary objective was to determine whether this approach would give you a better rate of success at your second TFR attempt. And this is the characteristics of the patients who had their imatinib stopped. So there was 131 of these patients, and you can see that they were relatively long on drug, 9 years median, 9 years on imatinib as a median, and 6 years of MR4 duration. So these were patients who'd had a long exposure and had MR4 for at least 2 years, in some cases many years. So of the 131 patients who stopped their imatinib, 58 had molecular relapse. So in fact, the majority were successful, but these were the 58 that we focus on for this re-challenge with dasatinib. So of these 58, 55 were able to go back onto dasatinib, and they did achieve a deep response in most cases quite quickly, which we'd expect. And that's shown here. I won't go through the details of that. But of the 35 patients who discontinued and had at least 12 months of MR 4.5 before stopping their therapy, rather disappointingly, 31 of them lost their molecular response, and actually relatively quickly. 4 have maintained their molecular response. So overall, the success rate with this strategy of switching to a more potent drug, maintaining deep response for at least 12 months and then stopping, is rather discouraging. And perhaps you could speculate that a longer exposure to a more potent drug would be needed to lift this success rate to a higher level. But it does raise the possibility that dasatinib, or a more potent drug, doesn't actually give you a great advantage in this setting. So based on these results, it looks comparable to the results from the French group and is somewhat discouraging from that point of view. So the final TRAD trial results indicate re-challenge is effective at restoring a deep molecular response, but 12 months of sustained deep response is probably not sufficient to allow you to stop with any great prospect of success. Okay, final study is the study from the Canadian group, actually from the Quebec CML research group, and this was led by Lambert Busk. Nice study in which they've looked at all of their patients in a real world setting. This is not trial data. And you can see that very much the majority of patients on their first line were given imatinib, 625. versus just 69 on Dasatinib and 94 on Nilotinib. Some of that would be determined by what was allowed by the health service at the time, but it certainly predominantly Nimatinib first-line cohort of patients. The question one of the questions they asked was, is there a better TKI in the real world? And they kept it very simple to say they want to see a drug that is efficacious, good molecular response, but it's also tolerable. Patients like it and stay on it. So they use this criteria of survival without switching. So patients remained on their drug, which presumably means that they were achieving satisfactory response and they were tolerating it. And just based on that criteria of SWS, they looked at their data since 2008, because that's when patients had a choice to switch to another drug. And you can see that in the green with the Imatinib, it's somewhat lower rate of SWS than it is with Dasatinib and Nilotinib, suggesting that there are issues with either intolerance or resistance with Imatinib compared to Dasatinib or Nilotinib. And if you divide it up according to whether patients went on a second-line therapy because of resistance or intolerance, the problem seemed to be mainly resistance. Here you see patients who switched their second drug because of resistance, as you might predict, much higher with Imatinib than Dasatinib or Nilotinib. And a little bit surprising to me, there was no difference in terms of chances of switching to another drug because of intolerance. It was similar across the three drugs. This is an interesting way of looking at the data, asking about patients who switched. Their first switch was for intolerance or for resistance, and what happened when they switched again and again. And to really simplify it perhaps too much, the message here is that patients who switch for intolerance often will switch again for intolerance. And in fact, you have a lot more patients who switch several times for intolerance than you do patients who switch several times for resistance only. It's actually quite rare to have patients multiply switching just for resistance. You can see in this analysis, and the ratio of switching for intolerance versus resistance in terms of serial intolerance and serial resistance was 6.6. So that really does emphasize the fact that we have a significant challenge with patients with so-called pan intolerance that's much more frequent than patients with pan resistance. Interestingly, Lambert's group also found that the survival was actually inferior for patients who'd switched more than 2 times, regardless of whether it was for resistance or intolerance. And that's somewhat provocative, but that was the findings from this registry. So TKI switching is frequent and mainly driven by intolerance in all switching events and with all available TKIs. Survival without switching is superior with second-generation TKIs in first line than with Imatinib, and in subsequent lines, it's similar. And Lambert speculated that, serial intolerance is more of a challenge for us than serial resistance, suggesting a class effect for intolerance, which, in fact, we might not see with Asciminib because of its very different mode of action. Switching more than twice, regardless of cause, is associated with a decreased likelihood of survival, which I think is an important and provocative finding that needs further investigation. So they were the studies that I wanted to present, and at that point I will stop and invite any questions.
Thank you, Tim. Thanks for the recording and also for being on the webinar today. So Giora, looks like you are first. Nice to see you.
Hi everybody. Hi Tim, good to see you.
Hi Giora.
The last sentence you mentioned, saying that patients who switch twice have worse chance of survival than patients who don't switch, and it doesn't make difference for what's the reason, intolerance or resistance. So I can understand that when you have resistance, you have to switch, you don't have any choice. But what does this mean though? If patient is complaining about side effects and intolerance of a drug, so should the doctor now insist of keeping him on the drug and not switching because you'll have worse chance of survival?
Yeah, so I'll say what I think, and then hopefully Lambert's on the line as well, and he can put his perspective. But I suspect a lot of this is related to the fact that many of the patients that switch for so-called intolerance have also got features of resistance. Maybe they've had big gaps in their therapy, and maybe they don't actually have very good molecular responses, but they've been assigned as intolerance. I personally have no hesitation switching a patient if I think there's a better drug for them. I don't think that has an adverse impact on their outcome. I want to get them on a drug they can tolerate, and that's a critical for their ongoing well-being. But Lambert, I think you're on the call,
Yeah.
so maybe
do
you'd
you
like
hear
to more
me?
perspective. Can
Do you hear me?
Can, yeah.
Okay, so I think it's we're looking into deciphering the cause and probably complex between resistance and intolerance, and we have to in the registry that the patient that are switched is a decision between the doctor and the patient, and probably they're the worst case, and sometimes they probably the exposure to the drug, which we're looking at now to see how much less exposure. So a drug doesn't work if you're not taking it or at a low dose. So we're looking now and combining the resistance versus intolerance, in fact, the response on those patients that were switched, to see what is the difference in drug exposure. So maybe it relates to the total drug exposure across the years that make you in a bad scenario. So we're looking into that now.
I mean, I suspect that patients who are switching several times, who are maintaining optimal molecular response, I suspect that their survival is very, very good. But maybe you could look at that, Lambert, because I think it's an important point that Giora raises, that we don't want to have patients very reluctant to switch because they believe it's an adverse effect on survival. If they're having optimal molecular response, I think it's very unlikely that it would have an adverse impact on survival. So, and particularly now we've got so many choices of good drugs.
Thank you. So I can't see any other
question
hands.
for Dominik, if there are no questions coming through, Nicola.
Great. Yep.
So Dominik, you this exciting data from Satu's group looking at stimulation of NK cells. I think that's one thing that we're all pretty excited about, the possibility that we can actually enhance their activity, because the data looks pretty impressive, that the patients who have even good numbers of certain NK cells have a much higher chance of success. I guess if we're going to do that sort of strategy, follow that sort of strategy, we need to be understanding where that benefit lies, because if the benefit lies in the activity of the NK cells prior to stopping, so they've actually depleted the critical population, or is the critical activity of the NK cells after you stop to prevent those cells from proliferating. If one of those was the predominant activity, that would help you design how long you use the drug for, when you use it, etc. So do you have a feel for that? Do you think it's both is critical, or do you think one of those two scenarios is more critical?
So thank you, Tim. I think it's very important when you look at this drug screening that they found SMAC mimetics, that there's still a reasonable number of leukemic cells, because it's obviously more an indirect effect, which is going over the modulation of the target cell, and not directly a strong effect on the NK cell population. I think they have to figure it out, whether you are really able to induce immunity in a status where you have very few persistent cells sitting in niches which are protected from the immune activation. And in this setting, you try to add a drug which is reacting over the target cell population. I think it's probably more important during the initial phase, where you have a lot of leukemic cells, and where the immune priming, including the priming of the adaptive immunity, but also the innate immunity takes place. And we all know that the classical setting, that innate immunity is something which has no type of memory. It's a different type of memory they have. They can be imprinted in a way where they impact later on the TFR likelihood, I think. So my feeling is that it's important during the earlier phases, and that it's not a drug which you add at the time point where you stop in MR4.5 or MR4, where you stop the TKI.
Yeah, so it might be during that consolidation phase where you've got a deep response, but you haven't got to the point of stopping. Maybe that's the time you could use it. Maybe not right at the start, where it might have an adverse effect on the response because of toxicity. Yep. Okay, thanks. That's really very important.
Can I ask you something, Tim, regarding the ASCEMBL trial? I mean, the Bosutinib data look a bit disappointing, and we have just recently assembled our data from the Bodo trial. which I've done with Tim. We had to prematurely stop, but we had roughly 60 patients where we have used the Bosutinib in a quite considerable number of patients in second line after second generation TKI, either failure or, and that I was very impressed by seeing in real world, and that's also my perception, that most of the patients are switched based on intolerance. But in this population, Bosutinib seems to be far more effective than we see it in the ASCEMBL trial. So the Bosutinib arm is a bit, let's say, disappointing compared to what we would expect, even though Asciminib is a very important drug and it seems to be superior. It's a well-controlled prospective trial. But what do you think about the Bosutinib arm?
Yeah, that's a common comment that's been made, that the number of patients coming off, the number of patients with severe toxicity seems to be higher than what people expect. I think some of that may be due to the fact that it was a multi-center trial where a lot of people were using Bosutinib who hadn't used it a lot in the past and maybe didn't have that experience of how to manage the gastrointestinal toxicity, and maybe modifying the dose in the first few months is critically important. I think that's something to do with it. So I don't think the Bosutinib data necessarily reflects what an experienced clinician can achieve with Bosutinib, but it reflects what happened out there in the real world, I guess, not the real world, but in the trial world at least, where many centers who didn't have a lot of experience with Bosutinib did struggle to get patients to remain on it. So, but I take your point.
Thank you. There has been a couple of questions come through on the chat to me, and so one about the Italian study. I'm not sure if Dr. Pane is still on the line. I thought I saw him earlier. But the question is, perhaps I will read the question and then hopefully someone will be able to answer. Does the randomized Italian study mean that a second generation TKI is now a better choice than Imatinib for patients who want to achieve TFR? Is Pane, is Fabrizio on the line somewhere?
Yes, I am here.
Oh, beautiful.
Excellent.
I am here. The SAHMRI trial investigated regarding those patients, the patient journey. In those cases, treatment-free remission is an aim of the treatment. Of course, there are many other types of strategy to manage patients affected by chronic myeloid leukemia, particularly in the cases in which treatment-free remission is not a reasonable aim of the therapy. That's why we placed as primary endpoints the MR 4.5 at 24 months and the rate of treatment-free remission after 4 years of the therapy. That's the structure of the study, and that's what the study want to demonstrate. And it's a peculiar situation but not uncommon for the treatment in chronic myeloid leukemia. The question is, what's the best option? We do not know at the moment, but of course, I think that the first results and the primary coin point at 24 months indicates that particularly the strategy with Nilo frontline is beneficial, particularly in patients with low risk ALTS, because it's practically twice as high the number of patients with low risk ALTS who have benefit from Nilo frontline respect to those start with the EMA despite switching to Nilo. after not optimal response during the first 12 months of treatment.
Can I just follow up on that, Fabrizio? So I guess what this study hasn't really looked at is the possible price that patients are paying in terms of toxicity for starting on nilotinib rather than imatinib. We know from the INSND data the very substantially higher rates of vascular events. I assume you've seen a similar thing in this study. I don't think you mentioned that, but is that also the case, that there's the substantially higher numbers of occlusive arterial events in the nilotinib arm, in the arm that started with imatinib and then selectively switched to nilotinib?
The early switch due to intolerance was very limited. So it's not possible to make a sub-analysis from the statistical point of view of the differential effect of switching for intolerance respect to switching for not optimal response in terms of efficacy of the therapy.
Sorry, I just wanted to clarify, was the number of vascular events on the nilotinib arm, was that similar to what was seen in INSND?
Sorry, I didn't understand because
sorry, I'll say it slower.
Out, please.
Sorry, Fabrizio, it's my Australian accent. Was the number of vascular events, myocardial infarcts, cerebrovascular events, peripheral vascular disease that you saw in the in your study, particularly in the nilotinib arm, was that similar to what was seen in the large randomized study like INSND or INSFirst?
Yes, but the comparator arm is the results for Nilo arm are quite similar to the previous trial frontline, such as NST, ND. Right. The results are slightly superior, but we explain this superiority given the enrollment in our country and in the specifically designed center with interest to CML. So expert physician in management of the drug took care about all patients. But the results are not so different in terms of a rate of MR 4.5 after 2 years of treatment in respect to NSND.
Thank you. Thank you. We have we've run a little bit over time, but perhaps I might address one final question if there are no further from the audience. Perhaps to both speakers. Perhaps you first, Professor Wolf. The data presented at EHA, how would that change the way that you would manage CML patients from now on?
Well, tough question. I mean, Asciminib is something which we more and more use in clinical practice. Last week, we had non-cerebral infarction with Asciminib. So this patient has not had prior nilotinib and also no ponatinib. So she has a risk profile, but actually that's the reason why we went to Asciminib. So I think we have to be very careful looking at those data, get more follow-up. But I think Asciminib is the most important practice-changing drug we more and more use also in clinical practice.
Okay, thank you. And Tim, can I ask the same question to you? How has the data changed the way you would practice CML now?
Well, I think the ASCEMBL data, from my perspective, just gives me more reassurance that Asciminib is, as monotherapy, is a very potent and effective strategy. Yes, we need to watch the vascular events as they unfold, but I think the incidence is likely to be substantially lower than what we see with Ponatinib. I think the other observation from the Italian study, that the benefit of starting with a second generation drug, certainly in terms of wanting to achieve a deep response and subsequent TFR, is predominantly seen in the low risk ALTS group. And I think we're seeing similar trend in other studies where the more potent drugs are probably giving the greatest benefit to the patients who are going to have the best results, which is interesting. And I think it has some impact on how we should select our drugs for frontline therapy.
Thank you. Thank you. And thank you both again for your time and experience and expertise. Really appreciate it.